Okay. This is my disclaimers. Decision making in planning surgery. It is 8:30 in the morning. You go into OR, you put up the X-rays, and you think what I'm going to do. And that's really what I'm going to discuss with you. Then through that we'll talk about classification and other things. But I put up the X-rays and decide now, is it going to be one curve fusion, two curves fusion? That's the X-ray on the left is right thoracic, left lumbar. Am I going to do both of them? I'm going to do selective fusion for the right thoracic. The X-ray on the right is double thoracic curve. The left shoulder is higher. Am I going to do just the right thoracic or do both of them and take care of the shoulder position? That's the first question. So he made a decision, and then he makes a second decision. Well, okay, now I know I'm going to fuse what? Where to start, where to finish, what I'm going to do in between, where I'm going to put to do the case. And that is my talk. So first question is to fuse one curve or more than one curve. And that's what Lenke classification tried to do to sort out. I have to get the picture up. Oh, it's up now. So for a sophisticated audience like you, I don't have to go through the details of classification. It's very popular now, everybody knows it. But just very quickly, the highlights. He tried to cover all the curves and in two planes, coronal and sagittal. So we have 6 types of scoliosis, and we have 3 modifiers for coronal curve or coronal classification into A, B, and C, depending on central sacral line in relation to the apical lumbar vertebra. And we have sagittal modifier, positive or negative, depending about the kyphosis of the thoracic spine. That classification is very helpful in decision making about fusion for the curves. He divided them into structure, non-structure, and if structure curve, of course, as we know from the old history, that you have to fuse it. Non-structure, how we know it, the side bending of the curve goes below 25 degrees, so flexible, and then probably, not always, but probably may not have to fuse it. So, and take in consideration, of course, the sagittal alignment, the kyphosis, and that if the spine is in lordotic shape, then that override the flexibility of the non-structure curve. This is just in a very simple terms, the classification, which you can read it anywhere, and it's so simple after you get used to it. But the advantage of that classification was to first decide the structure curve, and second decide that you're going to fuse a structure curve, and third decide if you're going to fuse more than one curve depending on the flexibility of the lumbar curve, if it is bending more than 25 degrees. And everybody agrees generally the classification works very well for most curves. The one curve which giving everybody a problem is 1C, like this curve here, right thoracic, left lumbar. The right thoracic is a structure curve. The left lumbar is flexible and side bending, goes below 25 degrees. The central sacral line is not touching or beyond the apical vertebra, so that be C is not A or B. A and B would be central sacral line going through the apex of the lumbar curve. And if you follow the advice according to classification, you fuse the right thoracic curve only, expecting the lumbar curve to correct by itself. Well, unfortunately, in many cases, decompensated this way. And then we have to make a decision when to fuse the lumbar curve for 1C. Everybody agrees that 1C is still controversial in decision making. So, really, when it comes to this question, this is a drawing for 1C, and the 3 pictures are 1C. The central sacral line in the first picture on the left, just beyond the apex, beyond the pedicle of the apical vertebra of the lumbar spine. Second picture in the middle, central sacral line is beyond the body or just touching the body of the apex of lumbar vertebra, still C. The third picture is far away from the apical vertebra, I still C. But all of them are not going to behave the same if you do only selective fusion. I got interested in that long time ago, it's about 20 years ago, when we had problem with using King-Mo classification for type 2, which comparable to 1C here, right thoracic, false left lumbar, and we start using CD system and we end up by a lot of decompensated patients. And I proposed and I presented that, and after long series review, that if we have the central sacral line touching the body of the lumbar vertebra, so that probably could be A, B, or C according to Lenke, then selective fusion is successful. But if the central sacral line doesn't touch the apical vertebra, anyway away from apical vertebra, I would fuse the lumbar curve as well. Let me show you some cases to explain that. This patient is 50-degree curve. Lumbar curve is 45 degree, and you can see in the side bending, the lower pictures, it's 10 degree in side bending, so it's clearly it is type A. It's not type 3. Sorry, it is type 1, not 3, because lumbar curve is flexible, non-structural. Central sacral line is just beyond the pedicle of the apical vertebra, so that's 1C, and then you do selective fusion and you have very good results. And important to look at the symmetrical waistline of the patient, because this patient, what's he asking for, not to be shifted to one side. Another patient, the same story exactly, 45-degree curve, side bending 23, so it is below the 25 degrees marker for Lenke classification, so it is type 1 curve. Central sacral line beyond the apical vertebra, so it is 1C. But look at difference here, and we did selective fusion, and she's very unhappy lady, because you can look at the flank and the flat lumbar area on the flank on the left side and the deep lumbar area on the right side due to the residual curve down there, and she is unhappy with her results. So that's another case to show that we have here the same story exactly again. This patient corrects to 27, 25, you can read it as 1C or 3C, but it's C. And side bending is reasonably flexible. It's calculated 27, but could be 25. So really that number, I'm trying to put this because the number is not really the issue, and I'm going to present what I propose for this. It could be 25, you shake your hand, make it 23. So it will be below the 25 marker. But the central sacral line far away from the apical vertebra. And this patient, I fused both curves. She has a symmetrical waistline. She's very happy with her outcome. I think if I did selective fusion, she would have been decompensated. Many people looked at that issue. What to do with 1C? Steve Richards, the coming president to SRS, had a good paper about this, and he proposed that if the lumbar curve more than 50 degrees, if the apical vertebra displays 2 to 3 centimeters, if there is a significant hump, and again it is 1C, then he fused the lumbar curve. I looked at it differently as a result of my previous reviews when we used to King classification. I think it is better than number is to look at flexibility. If the curve flexible more than 50% on side bending, that I consider a flexible curve regardless of the numbers, and of course all this point has to be taken into account, and that one I don't fuse is the flexibility less than 50%, then I'll fuse a curve. The trunk shift to the left, that's very important regardless of the number, because also the patient, you do selective fusion, you'll end up by flat flank like number 2 cases I showed. And of course if you have a lumbar hump, but most important thing, the central sacral line is beyond the apical vertebra. It's not just touching or 2 centimeter far away. If it is beyond the apical vertebra, 2 millimeter or 2 centimeter, those usually they don't correct by fusing the thoracic curve only. They do compensate. Applying this for over the years, it shows that it gives you good results. So we summarize this part is the guideline by Lenke classification are applicable, except when you deal with 1C, you have to look at other criteria. So you made a decision, you're going to fuse one curve or two curves. The second question, where I'm going to start proximally, where I'm going to end distally. And beginning or proximal fixation is the shoulder level is the function of the proximal fixation. And we have three possibilities. We presented this paper in Buenos Aires showing the result of that classification. Either you have a level shoulder, right side looks the same as left side, like this patient. Then really you have to start from a horizontal vertebra, proximally. You go to oblique vertebra, you throw the shoulder off balance. This patient end vertebra is T5, horizontal vertebra T3, fuse her to T3, and you maintained leveled shoulder. Other possibility is the left shoulder is lower. Then really you need to bring the end vertebra to be horizontal, so you can push the left shoulder up. Again, here is the end vertebra is T4. I went to T3 because I wanted that vertebra to come to be horizontal, and now you brought this shoulder up. Last possibility is the left shoulder high, and that means you are dealing with double thoracic curve. I would fuse the thoracic curve, the high thoracic curve, even if it is not structural, even if it doesn't bend below 25 degrees. It does bend below 25 degrees because the left shoulder higher. If you don't get that curve fused and pull it down, shoulder will not be leveled. In this case here, we went up to T2, end of the thoracic curve, the upper thoracic curve, and the shoulder is leveled. You made a decision. You're going to fuse one or two curves, then where you end distally. I use a side bending criteria we learned from Debussy a long time ago. The vertebra, which I call it the free mobile vertebra, L3 here, you bend in both direction, and you see the disc open in both direction nicely, and the vertebra comes back to be horizontal parallel to the pelvis in the side bending to the right. So if you look at this X-ray with the central sacral line, if you want to look at the stable zone, you end up by going to T4. But using this Debussy criteria, you will go to T3 and you end up with good results. Last part, if when you finish the case, we compress and distract in both sides, so we can create horizontal T3. This is the same patient. T3 is parallel to the pelvis now, using distraction compression in both sides to bring L3, L2, L1 horizontal and parallel to the pelvis. Sorry, I used T, word T should be L3. Of course, all of us now using the direct vertebral rotation to get rid of the hump, and that's very effective. As a result of that, we don't do very much thoracoplasty anymore. One case presentation, this patient here, right thoracic curve, Lenke 1B, proximal end vertebra T4, left shoulder is lower, and distal mobile vertebra is L1. So fuse her from T3 to bring the shoulder leveled to L1, which is, as you can see, side bending. It's very mobile vertebra. With its selective fusion, she has a very good outcome. Another patient, 1C, and you can see the central sacral line beyond the apical vertebra, and she has a significant right thoracic hump. And for her, I did both curves fusion, and end up by symmetrical waistline, level shoulder, and we went up to the horizontal vertebra T3 to avoid through the shoulder off. It is starting leveled, ended leveled. So in conclusion, outcome will depend on poor planning. Lenke classification is effective, except in 1C you have to make other decisions, and the proper decision, one or two curves, where to start, where to end, what to put in between. Thank you very much.